Everyone can see that.
Yes, that is perfect. Great. So we have both of the sessions. So the stream is going to be coming up. Super. All right. Look, we did all of that and we're like 4 minutes early.
I'm available to lead you in song.
Oh, that's okay. We don't want to
Okay.
run out of time.
Ha.
Okay, so at 58 in a minute, if you guys all want to just turn off your mics and turn off your cameras, we'll start so that everyone can come in. And then Caroline, at the top of the hour, if you want to start the welcome and the introduction, we will be off to the races.
Sounds good.
Awesome.
Good morning or good afternoon, wherever you may be located today. We appreciate you joining us. I'm Caroline Egan, President of Benefits Alliance, which is an association made up of group benefits and group retirement experts in Canada. We educate and advise thousands of plan sponsors across Canada and look for opportunities to share relevant and timely information and practical tools and solutions. With that said, Benefits Alliance is very pleased to partner with SunLife today to deliver this session called Trends in Pharmaceutical Benefits. By the end of our session today, you will have 3 takeaways. First, you will understand current key strategic trends, drivers, and influences in pharmaceutical benefits. Secondly, you will take away solutions to support drug plan sustainability, given the key trends and influences. And finally, you'll take away tools and resources will be shared to help with mental health and attention deficit hyperactivity disorder. Please note that today, throughout the session, please feel free to add your questions in the chat box and we will be addressing those at the end. So let's get started. I will introduce our two presenters who are both part of the Pharmaceutical Benefits and Innovation team at SunLife. It's my pleasure to introduce to you Denuja Raventhiran, Senior Benefits Strategist. As a benefits strategist, Denuja works together with members of the Pharmaceutical Benefits team to support strategy and development, acting as a subject matter expert. Together, the team takes part in dedicated efforts that balance access to care and plan sustainability. Denuja is a pharmacist by profession, currently licensed and practicing in Ontario. She has a background in pharmaceutical marketing strategy through which she brings key clinical insights. She continues to draw from her previous experiences in a range of pharmacy practice and patient care environments. Denuja holds a doctorate in pharmacy from the University of Waterloo and a Bachelor of Science, double major in medical science and biology from Western University. Please join me in welcoming Denuja. Our second presenter, who will be kicking things off today, is Tyler Bergh, Assistant Vice President of Pharmaceutical Benefits and Innovation of Group Benefits. As Assistant Vice President, Tyler leads the Pharmaceutical Benefits and Innovation team for SunLife Canada Group Benefits. He is accountable for SunLife's pharmaceutical benefits priorities and developing strategies that help balance plain sustainability and enabling access to care while helping our clients live healthier lives. Tyler has been with SunLife since 2002 and works from Vancouver. He has more than 20 years of experience in group benefits, including leadership roles, client relationship and management, and underwriting. Tyler holds a Bachelor of Commerce in Risk Management and Insurance from the University of Calgary. He also has a Certified Employee Benefits Specialist designation from the International Foundation of Employee Benefits Plans. Thank you for joining us, and please kick us off, Tyler.
All right, thanks, Carolyn, and good morning, good afternoon, and thanks for joining us today. So again, we're going to split this presentation kind of into two parts. So I'm going to kick things off initially, kind of going through some high-level trends on our block of business and also talking about some strategic drivers, influences that we're looking at in our product development and portfolio, at which point I'm going to turn it over to Denuja to, again, walk us through some products and solutions that might want to think about in terms of alignment with those trends. And then a really important topic today, and that's mental health in the workplace. And Denuja is going to take us through some data, pharmaceutical specific in terms of mental health, with a bit of a deep dive into attention deficit and hyperactivity disorder. So to start things off at a high level, just level setting in terms of prescription drug spending in Canada. When we look at CIHI data for 2021, the forecast is around $37 billion in prescription drug spending, and this is not including over-the-counter medications. But what often is interesting as we get into discussions is the split of those, and about 45% of the prescription drug spending in Canada is government. So when we think of seniors programs, social services, hospital funding, of that nature, but 55% of prescription drug costs in Canada are reimbursed through what might be individual plans, out-of-pocket costs, or a huge portion of this are group insurance or employer plans, which is important to this the audience today. When we're looking more at the disease category level, again, just to kind of level set on some things, again, these are our top 10. So this is the SunLife block of business. Depending on what industry information you're looking at, again, it tends to be diabetes, rheumatoid arthritis, inflammatory conditions as number one and number two. And in our block, the last 2 years, diabetes has been the number one health condition within our drug spending. A couple of factors for that have to do with, one, some newer therapies that are higher cost in the management of the treatment of diabetes, as well as the growth in some of the diabetes monitoring equipment. And then second is increased prevalence on that category. And this is one, again, we'll highlight that we'll want to be a continued watch as we look to the future, as when you look at information from Diabetes Canada, projections, another 1 million Canadians will be diagnosed with type 1 or type 2 diabetes over the next 10 years. And so this is a category to continue to watch. And then rheumatoid arthritis is our second category, with skin disorders number 3, and this is also a growing category. We've also provided the percentage of overall claims, and so this is, the number of claims flowing through the plan. And so again, you'll see some categories which have a higher percentage, which would indicate, traditionally associated with more chronic diseases where there's some lower average cost medications in the data. And then you'll see others with very small percentage of overall claims. And again, this is tending to be where the specialty medications sit, those at $10,000 per year, more of higher cost. And again, we'll talk more about that later. So now I just wanted to cover off, again, kind of 4 key themes that we're kind of looking at as a group in terms of setting our products and looking at the future. And so government focus on this area, growing specialty drug costs, an evolving biosimilar landscape, and then an aging Canadian population and the implications on chronic disease. So when we look at the government side of the equation, again, very active in terms of the government focus in 2022. And so we thought we'd highlight kind of three topics that would be of interest, again, in terms of the audience we have here today. And the first is national universal pharmacare. And this topic in itself is not new. It's been around for decades. But the interest picked up again earlier this year with the Liberal NDP supply agreement. And in there was a commitment to passing a Canada Pharmacare Act by the end of 2023, and also reference to national formulary of essential medicines, a bulk purchasing plan, all of which we'd be very, very supportive of. One of the key differences we wanted to highlight between some previous discussions on this file is all parties involved have been very careful not to use the term single payer in any of their discussions. And so we believe the focus right now is on a fill in the gaps approach, focusing on underinsured and uninsured Canadians, again, which based on some recent data, such as the updated Conference Board fill in the gaps report, would put the number of uninsured Canadians around 3%. And so this is our view right now, especially with some of the other government commitments they made, such as the recent dental care program. On the second one is the Patented Medicine Prices Review Board. So this is a quasi-judicial body in Canada who's accountable for ensuring, prices for patented medicines aren't excessive in the country. And again, talk about changes to some of their guidelines have been going on since 2019 and have taken various paths. The pandemic delayed some of this. There was various court and legal challenges with some of the proposed amendments. And earlier this year, the health minister did announce some amendments to be effective July 1st. What the amendment is largely focusing on now is changing the basket of comparator countries we use in assessing the prices, and moving from 7 countries we use today to 11. But this involves dropping 2, the US and Switzerland, which are 2 of the higher priced countries in the listing, and replacing with 6. So again, this should be beneficial in terms of new prices for patented medicines in Canada and some existing medications, but the PMPRB was not able to implement the guidelines for July 1, and so we're in a period of status quo right now, and this file is actually open for consultations right at the moment, and so would watch for more information on this one once those close or early in December. And the last one we wanted to call it is drugs for a rare disease strategy. So again, this was referenced starting in 2019 in the budget, and it proposed up to $1 billion in funding starting this fiscal year, with up to a $500 million per year ongoing commitment from the federal government. And some of the goals of this strategy were to improve access, ensure funding based on real world evidence, and a sustainable system. And again, we're very supportive of those goals. When we look at rare disease, again, these are again by definition diseases that impact a lower percentage of the Canadian population, a higher prevalency in like the pediatric population, and again because of the smaller population numbers, things such as like evidence in clinical trials, real world evidence of efficacy are more difficult in some of these areas. And so on this right now, we're expecting a framework out from the government later this year, early 2023. And again, our main position on that framework is the employer group benefits or health side has to be involved in that as a stakeholder. For context, the insurer community pays more in rare disease drug claims already than the $500 million ongoing commitment. So in terms of meeting the objectives of the government, we believe it's important all stakeholders are included in that framework. The second grouping I wanted to talk about in terms of the trends is growing specialty drug costs. And so I don't want to spend a lot of time on this one because pretty much you look at most industry benchmarking reports, trend reports, this is going to be trend number one that's listed in a lot of these references. And so we thought we'd give you a bit of a different view today. And this is some of our own internal data. And so we have a drug review team, including clinical pharmacists that are accountable for our drug pipeline monitoring and formulary listing decisions. And so this is a bit of a look at the data from our own internal data. When we look at the drugs we reviewed last year, which we would include biosimilars in that, over 60% of them were specialty in nature. And definition of specialty we'll use today is over $10,000 per year in expected annual costs. And when we look at our data this year, the trends are not any different. And again, looking at the pipeline, we do not see that slowing down anytime soon. And again, when we look at some of the categories that we're seeing, like oncology, very prevalent in those, and then rare disease and skin disorders we talked about earlier. When we look at some industry reports like the TELUS Health Annual Trends and Benchmarking Report for 2022, again, that data showed that, again, the number of eligible, the number of claimants went from 1.3 to 1.4% of total claimants. The percentage of eligible costs submitted through the plan went from 32 to 34%. And again, with their projections, if the current trend levels continue, could reach 50% by 2026. So again, this is an important area of focus. And so, and Denuja will talk about later in terms of some of the ways in terms of cost mitigation. But again, showing another subset of data where we're showing some of the growth in our own prior authorization program when we look at an increase in the number of claimants accessing the drugs, an increase in the cost of drugs coming down the pipeline, and then again, a raw increase in the number of drugs we're reviewing. And the last one I'll kind of talk about on this topic is we talked about the top 10 categories. We'll now take a view on the top 10 drugs. And we wanted to call out a few things in terms of this that may be of interest. 5 of the top 10 drugs shown in this are specialty in nature. So those 10,000 and above I talked about earlier. And 6 of those top 10 are on our standard prior authorization programs. Those 5 specialty that I referenced would all be biologic drugs, which again will be of interest when we go to our next topic. The other one I wanted to call out is, again, when we looked at our top categories, we will see that diabetic medications are 4 of the top 10, with a couple of the drugs showing upward trends in terms of their ranking year over year. The last one I'll call out on this are drugs number 1 and 2 being Remicade and Humira, and very relevant as we go to our next slide, as there are some tailwinds when we look at those which have been the top expenditure drugs on private plans for a number of years when we look at the evolving biosimilar landscape. Because you will see Remicade and Humira both have biosimilars, and so we'll talk about that topic next. So first of all, the level set, when you hear the term reference biologic or originator biologic, that would be the originator patented medicine. Whereas when you hear the term biosimilar, this would be a post-patent product that is similar to the biologic that was already authorized for sale by Health Canada. These drugs are not considered generic alternatives. And so the rationale being these molecules are extremely large and complex and made with living cells. So there's natural variability in these products. That being said, there is a lot of opportunity for savings. And so when we're thinking about product design, formulary design, discussions with manufacturers, again, there are some tailwinds in this area as more products come to market. And the other thing that's influencing this is the changing provincial landscape, which obviously impacts private plans. Provinces have been implementing switching initiatives on their own programs. And so this started in 2019 in British Columbia. And when we say switching programs, again, we're referring to that where the members asked to transition from an originator biologic, if that's what they're on, to a biosimilar medication with the support of their physician or specialist. And again, we do see provinces who have now successfully kind of transitioned, or those that are in progress as shown on the slide, with the most recent one being Saskatchewan actually announcing an initiative last month targeted for implementation for May next year. And the last trend I'll kind of talk about, and then I'll turn it over to Denuja to carry us on to the next part of the presentation, is the aging population and chronic disease in Canada. And so very important implications as we look to the future in drug plans, because probably not surprisingly, as we age, we tend to claim more medications and our average annual cost tends to increase. And we're showing this in our own block of business data at the different demographic cohorts. We also know in Canada, we have an aging population, so an expected 70% increase in seniors, and with that, an average increasing age in our workforce. And so when you think about an aging workforce with higher annual claims as we age, obviously that has implications on plans. We did want to call out that in this data, you may be wondering why post age 65, the paid claims amount drops. And again, those yellow bars is paid claims amount. And so this is showing the impact of provincial seniors programs post age 65 taking part of the costs when we look at the data. So in terms of driving why expenditures increase over time as we age, often associated with chronic disease. And so we thought we'd give you a bit of a different look in terms of the data on that. And that's getting with disease states that are shown in the data. And again, taking a bit of a different look on that. And so when we look at common areas like diabetes, elevated cholesterol, hypertension, again, we'll see the graphs show a very similar pattern to what we showed in terms of our cost growth. And so again, showing the prevalence of chronic disease as population age. And one that we wanted to flag, and Denuja will take a deep dive into this in a couple of minutes, is another chronic condition, again, that we saw a substantive change in our claims experience and through the pandemic, and that perhaps not surprisingly is mental health claims. And so this was driven, though, at the front end of the demographics, largely in the under 30 population. And again, showing some data and just changes between 2018 and 2020 on both drugs and paramedical practitioners. And Denuja will share some updates on that data in a minute. And so the last aspect we want to talk about when we're talking about chronic disease in an aging population is claims increase, chronic disease increase. But when we're thinking about product design supporting plan members, we also need to be thinking about a couple elements. You know, often when we talk about drugs, we talk about specific categories, but that's not most members' health journeys. And so a couple other points we wanted to make here is as we age, not only is it one chronic condition often that we're dealing with, but the number of people dealing with multiple chronic conditions increases over that time too. So again, when we're looking at those categories, it's often multiple categories in chronic condition. And the graph is a population study in Ontario for this purpose. But the other one we need to comment on is comorbidities. So again, often people dealing with a chronic condition, there's other conditions at play, and a good example is the 30% of diabetics living with relevant depressive symptoms. And so as we are thinking about products or supports for members, we need to look at that holistically, recognizing it's more than just the disease states that's showing up in the drug data that's impacting their journey. And so I'm going to close talking about a journey a little bit and how we're thinking about product design and again supports. And this is a journey that actually exists at SunLife today, but one that we would look to supplement and augment in the future. And something to think about is, as Denuja is going to talk about later, about our mental health coach pilot and some of the results in a program we're launching in the new year, and how that could be adapted to some other journeys. So this would start up front. So Mary, who's a type 2 diabetic, she's been diagnosed. And so Mary's going to access the Lumino resources and offers, which is available on our mobile app or our website, where there's information on various categories of information, one of those being chronic disease. And in that, Mary finds information on the BANT app, which she downloads, which helps her simplify her diabetes management. Our digital coach, Ella, might then provide Mary some information, who's a regular metformin user, that the medication's eligible for a 90-day supply, which can help save Mary and the plan money by filling at longer intervals. Mary's recently moved houses, and so in her new location, Mary's going to use our Lumino provider search to find pharmacies in her area from a convenience perspective. But through that, we're also going to provide cost transparency information on dispensing fees on those pharmacies that are below, at, or above reasonable and customary dispensing fee levels in her community. So Mary can make both a convenience and a consumer choice. In recent conversations with her physician, Mary has also been prescribed Ozempic as part of her diabetes therapy. And so with that discussion with her physician, Mary uses SunLife's drug lookup tool. In that discussion, finds out the drug is indeed covered under her plan, but it is subject to prior authorization, at which point Mary can then access the form. Those would be completed in partnership with Mary's attending physician. And Mary can then submit those forms either through photo submission or uploading through our website, at which point they're reviewed within 5 days. And at that point, Mary's going to receive a phone call from our preferred pharmacy network partner telling Mary that she's been approved for the new medication, opportunities for savings through the preferred pharmacy network and delivery options for Mary, as well as other supports such as financial assistance, counseling, or health supports that are available through that offering. And so again, just wanted to talk about a bit of an example of a journey and very much how we're looking in terms of some of our product design. And so with that, I'm going to close off and say thank you. So again, we've kind of gone through kind of 4 strategic kind of drivers and trends that we're thinking about across our block. And so I'm going to turn it over to Denuja now to talk about products and solutions that can assist with some of those trends.
So hi, everyone. I'm glad to be speaking with you all here today. And thank you to Tyler for that awesome overview of policy and the pharma benefits landscape. So now we'd like to discuss some of the solutions that support drug plan sustainability, including specific products and programs. So I thought I'd dive right in and start with formularies. Formularies being the specific list of drugs that are covered on a plan. And there are a lot of options here. They include open formularies, which cover all prescription requiring medications. There are also managed formularies, which may be multi-tiered or provincial mimic plans that are designed to control costs while ensuring that most therapeutic options are available. And then there are also custom formularies, which are built to meet a plan's unique goals and specifications. Now, formulary management is really just one piece of the puzzle when it comes to managing drug costs. And in fact, there are multiple products that serve as additional cost containment features that can be layered on top of the formulary that's selected. So these include various traditional drug products, so things such as mandatory generic substitution, which ensures that claims with a generic version are cut back to the lowest price equivalent drug. And this would be even if a doctor were to write, no substitution on the prescription. There are also dispensing fees or frequency limits. This is where there's a limit on the dollar value or the number of dispensing fees that are eligible for reimbursement. And then other things like trial programs, which enables a pharmacist to dispense a smaller supply of a medication, so perhaps maybe a week's supply, that gives an employee or a plan member the opportunity to just test out a medication and see if they're able to tolerate it prior to then filling, the balance of their script, which may be like 30 days or 90 days, whatever it is. Now, all that being said, what really may be on top of plan sponsors' minds are specialty drug products. Now, there are a number of solutions that are available to support plan sustainability when it comes to managing specialty drug products. So I'd like to take a few moments now to explore that a little bit and then talk about some of the most common cost containment tools in that area. So I'll first talk about our drug review process. And you can see here it's illustrated on the slide, an example of what that drug review process might look like. A number of private insurers have introduced a similar process. And what this is really doing is adding an additional layer of review, and it gives insurers this ability to sort of pause the review process of automatically adding new drugs that are coming to market to plans. Now, these review processes by private players are very similar to what is undertaken by provinces on the public payer side. So, for instance, a province may use recommendations from health technology assessment organizations, so HTAs, like CADIT or perhaps INIS in Quebec, to inform their drug listing decisions. Now, very similarly, on the private payer side, their drug review processes also inform listing decisions, although the pharmacoeconomic perspective that a private payer takes can be a little bit different. For example, they may be prioritizing objectives such as employee productivity or presenteeism or absenteeism, things like that. Now, drug reviews tend to be completed by subject matter experts, so often a partnership between clinical pharmacists and health economists. And this is really to ensure that the best choices are being made in terms of drug efficacy and value. Also important to note is that this review process applies to both new drugs that are coming to the market and are approved by Health Canada, but also for existing drugs that are now receiving additional approval for treatment of a different medical condition. A comprehensive review can include a multitude of different components. So things like comparative analysis of drug costs and its clinical effectiveness, recommendations by HTAs, again, like CADIT, availability of other drugs that treat the same or similar conditions, and then overall just really looking at plan sustainability. Now, through this drug review process, it's ultimately going to be determined which drugs are going to be covered under the insurer's plan and under what conditions. So you can see here on this slide, there are about these three outcomes. One is that the medication is covered and it's listed as a general benefit, meaning that a member is able to go to the pharmacy, have the claim submitted and paid. Another option is that the drug may be excluded from coverage altogether. And then in some cases, a drug may be added to the prior authorization program. So that's something I'll explain on. I'll expand on. So on the next slide here, you'll see prior authorization, which is not a new concept. It is definitely a standard in the industry. And in fact, across Canada, all provincial plans have their own version of a PA program. So this is very much a part of the clinical framework. Physicians are certainly aware of it. PA programs tend to limit or tend to target a limited number of drugs, and it requires that these drugs be pre-approved for coverage. Now, in order to be approved for coverage, plan members need to meet specific medical criteria, and these criteria are set with an aim of targeting those plan members who are most likely to benefit from use of the drug. So, overall, PA is a safeguard to help ensure that insurers are approving the right drug as part of our claim processing. The next thing I'll talk about is preferred pharmacy networks, or PPNs. Now, the availability and access to PPNs is certainly another strategy to help ensure long-term plan sustainability, but it can also allow for a really optimal plan member experience. There are a variety of PPNs available, and just broadly, I would say categorized in two, so closed PPNs and open PPNs. Closed PPN is one in which a plan member will only get coverage for their medication if they were to take their prescription to a PPN pharmacy. Now, an open PPN is one in which a member can take their prescription to any pharmacy and their coverage will not be affected. There are also PPNs that include both specialty and chronic medication coverage, while others may focus exclusively on one or another. So in essence, PPNs offer the opportunity to leverage exclusive savings on select medications and reduce the cost of prescription drugs. As I had mentioned before, there is an opportunity here for plan members to have a really great experience, and that's because these PPN pharmacies are able to provide additional value-added services. So this can include a wide range of things, but to name a few, perhaps getting home delivery of medications, access to speak to a pharmacist 24/7, having their medications administered at a clinic perhaps. So various value-add services. Actually another one I'll add is perhaps case management to help facilitate access to medications. So moving along, I will now talk about biosimilar management approaches. And so this is actually something that Tyler had introduced at the beginning of our presentation. And what we know is that some public plans have mandated switching from biologics to biosimilars. But in the private payer space, we are seeing a number of different approaches to biosimilar management. And oftentimes it's a combination of certain approaches. And so those include preferential listing of biosimilars on prior authorization programs. So I discussed PA programs, and in this context, what I'm meaning is that biosimilars would be preferentially listed over biologics as part of the PA criteria. So this would ensure that plan members who are new to treatment are using a biosimilar as their first treatment. There's also reference-based pricing, and this would entail limiting reimbursement to the price of an originator biologic. this would limit the price to a biosimilar, So basically, this is a really great option because the plan member is still retaining access to both the biologic as well as the biosimilar. But if they were to opt to maintain use of the biologic, the originator biologic product, they would be required to pay the difference in price out of pocket. The final one I'll mention is product listing agreements with pharmaceutical manufacturers. And this refers to negotiated discounts that help to bring down the price of originator biologics more in line with their biosimilar options. Now, I'll expand on that a little bit more as well on product listing agreements. And this is actually interesting because it doesn't just apply to biologics, but to a variety of different drug categories. So product listing agreements, or PLAs, they are agreements between drug manufacturers and insurers and are negotiated contracts which confidentially determine the specific terms under which an insurer agrees to reimburse a drug. What's great about this is that it's really a great balance between making high-cost drugs that are often new drugs, they're often innovative drug therapies, more widely accessible to plan members, employees, but in a very cost-efficient way for employer-sponsored plans. Now, there are a variety of mechanisms or ways in which PLAs can be administered, and these can include discounts that reduce the per unit price of the drug. There are also outcome-based PLAs, and there can also be an implementation of a cap, so a quantity or dollar maximum as another means of just reducing the overall charges to benefits plans. An interesting question might be, who is negotiating these contracts? On the private payer side, as I mentioned, it's the individual insurers or pharmacy benefits managers who are negotiating PLAs on behalf of their plan sponsors and plan members. On the public side, it is the PCPA, which is the Pan-Canadian Pharmaceutical Alliance, and they deal with negotiating agreements between drug manufacturers, so both brand name as well as generic manufacturers, and the provincial, federal, or territorial drug plans. So now that we have reviewed the current policy and pharmacy landscape with Tyler, and we've now just gone through some opportunities to enhance plan sustainability, I'd like to move to the final segment of our presentation, and that's going to be a focus on the emerging mental health trends with a specific spotlight on attention deficit hyperactivity disorder, ADHD. So to set the stage, what we know about mental health disorders is that 1 in 5 people in Canada will personally experience this type of an illness. And to provide further emphasis on this, in Canada in 2021, life and health insurers paid out $580 million for mental health support. And that's in fact 45% up from 2021 and a 75% increase from 2019. So it's undoubted that mental health is one of the key issues of our time. It includes many domains of our well-being, from our emotional, psychological, to our social well-being. And it can affect the way that we think about ourselves, how we relate to others, how we interact at work, and just really the world around us in general. Now, a diagnosis of mental illness is quite broad. It's quite a broad umbrella, and beneath it is various different disorders. So this includes depression, anxiety disorders, mental health conditions like schizophrenia, of course, ADHD. The commonality between all of these disorders, of course, is that they all reduce a person's ability to function, and it can impact their quality of life significantly. So taking this back to ADHD, ADHD is commonly perceived as a disorder that affects only children. And you'll hear more today about its prevalence in the working age population as well. And I think that's a really important trend for employers to consider, just in the broader context of mental health, because truly, it's interesting that 85% of adults with ADHD actually meet the criteria for a comorbid or concurrent mental health condition. So it's often not a standalone disease. Now, the good news is that mental illness, including ADHD, can be managed extremely successfully using both drug and non-drug therapies to help people recover, maintain their day-to-day functioning. And employers can play a really important role in this in supporting their employees through workplace benefits. So I'm going to actually provide a quick overview of ADHD, and then I'll also talk about the impact that it can have on everyday life. So attention deficit hyperactivity disorder is a neurodevelopmental disorder. Symptoms typically appear in childhood, as I had mentioned, and usually onset is prior to the age of 12, but it can definitely continue into adulthood. Now, the cause of ADHD remains under investigation, but what we do know is that parents with ADHD have a better than 50% chance of having a child with ADHD, and about 25% of children with ADHD do have, in fact, a parent who meets the formal diagnostic criteria for ADHD. The prevalence is estimated to be about 5 to 9% for children and adolescents, and about 3 to 5% for adults. Now, there is a common public misconception, and it's often reinforced by media, so I want to mention it, is that ADHD is overdiagnosed and perhaps overprescribed medications. However, if we do look at studies that have been conducted recently, and namely a recent meta-analysis, we can actually confirm that the rates of prevalence of ADHD have been quite stable over the past 30 years. Now, in terms of symptomology, adults with ADHD can sometimes be very easily distracted. They may struggle with mental restlessness, disorganization, perhaps procrastination. There may be some difficulty with starting and completing a task, and managing their time, or even controlling their behaviors or impulses. Now, as I mentioned, the treatment is usually a mix of both medication and therapeutic and behavioral approaches. And what's really great to call out is that medications in this space can be very, very effective. They typically have positive effect on the 3 hallmark symptoms that are inattention, impulsivity, and hyperactivity. But I will say that a comprehensive multimodal approach that includes psychosocial interventions are definitely the most recommended approach to treatment. So now moving to the impacts on everyday life. I'm sure you could glean from what I've said so far that ADHD symptoms can profoundly affect someone's personal and work lives. And it can potentially lead to a chronic sense of underachievement, low self-esteem. In fact, adults with ADHD have higher absenteeism and lower productivity in the work setting. And they often channel their physical restlessness into work, perhaps sports activities, and some may even self-medicate with stimulants, things like caffeine or nicotine, or perhaps illicit drugs. Now, over the course of time, the symptoms of hyperactivity and impulsivity can go down. And that's something you may have heard people saying that, a child can outgrow ADHD. So this is sort of in contrast to the symptom of inattention, which doesn't typically go away as you get older. And oftentimes, the comorbidities do tend to increase as one ages. And as I had mentioned, up to 85% of adults with ADHD do meet the criteria for another comorbid mental health disorder. So we're talking about things like concurrent anxiety or depression. So I want to take a step back now and just to help you consider mental health benefits programs through a comprehensive lens, I want to take a closer look into certain data trends in the mental health and ADHD space. And in particular, what we've been observing across the SunLife block of business for the past few years. So you can see here on this slide, these 2 graphs depicting mental health drug trends. And when we look at this broadly, what we see is that drug claims are growing. The first graph on the left here represents mental health drug claims. The dark blue is the percent of total drug spent. The yellow is the percent of total drug claims, and this turquoise color is the percent of total drug claimants. So what we can see is between 2017 to 2021, there has been a slight increase in the percent of total drug claims and percent of drug claimants. Now, if we were to look at the next graph, the graph on the right, we pulled out the mental health drug claims from 2018 to 2021. And what we see is that the claims have actually been increasing since 2018, with a significant peak in growth in 2019. And then thereafter, it's sort of stabilized at a higher amount. But what this tells us is that the number of claims for mental health drugs were already increasing before the pandemic, which is something we know would have exacerbated this trend further. I also just want to caveat, when we talk about mental health drugs, we're referring to the drugs that treat various mental health illnesses that include depression, include anxiety, include insomnia, stress and sedation, ADHD, of course, but then also several antipsychotic medications that would treat conditions like schizophrenia and bipolar disorder. So just to give some context there. So on our next slide, I will show you these additional graphs that kind of depict the claim impact of mental health drugs. So on this graph on the left, we see the number of claims broken out into their various specific disease states. So this is claims from 2018 to 2021. And what we can see very easily is that depression, which is this dark blue line, is by far the largest driver of mental health drug claims. Now, while the other drug categories appear to be less significant, if we were to turn our attention to the graph on the right, we've pulled out ADHD claims specifically. And what you can see, in fact, is that between Q1 of 2018 and Q4 of 2021 is that there's been an increase by 67% in the ADHD drug claims. And this is actually a trend that's continuing in 2022. Now, I would like to compare this to the overall drug claims growth in mental health overall. And for that same period, it was 28%. So, it's clear that the 67% increase is in fact quite notable. So that was SunLife's block of business. And what we did after that is we actually reviewed some of our data against data that we've been seeing across the industry. So on our next slide here, what we did is we reviewed our data to industry level data from TELUS Health's National Drug Report of 2022. And what the reporting showed is that the category of drugs used to treat ADHD and narcolepsy rose from 7th to 6th position in 2021, overtaking the cancer category. And I found this really interesting because 5 years ago, they had reported that the category ranked 10th percent. And now we're seeing in 2021, that has increased to the sixth position. Sorry, so previously, just to be clear, it was at the 10th position and now at the 6th position. So what they've said about this, what TELUS has said about this, is that this relatively consistent growth rate for both eligible drug amount and the claims indicates a growing patient population. Now, a potential explanation for this could definitely be the increase in online schooling that we've seen, the increase in working from home, and really an opportunity for individuals to be more acutely aware of their symptomology. Maybe it's just a difficulty focusing in front of a screen, for example. So we continue to review our claims data against industry, and on our next slide, we see claims data from IQVIA, and what we see. Sorry, so it'll just be on the next slide here. IQVIA claims data shows a rise also in the number of ADHD drug claims across the industry. And in fact, their data showed that ADHD was the therapeutic class with the highest year-over-year growth in drug costs between 2020 and 2021. In addition, the number of claimants grew by 15% year over year, and the majority of this growth was driven by an adults working population, so from the ages of 15 to 44. I also thought it was kind of interesting to note that at a provincial level, they had reported that Quebec is known for its highest incident rate of ADHD. And they had said that perhaps a reason for this is a greater willingness or a greater acceptance of seeking medication, and similarly, greater willingness to prescribe on the part of the physician. So in 2022, SunLife partnered with Ipsos to conduct a survey on the importance of diversity, equity, and inclusion practices in group benefits. Now, the survey showed that many people continue to face mental health challenges and accessing care remains difficult. In fact, affordability and embarrassment were the two top barriers that people had mentioned were preventing them from seeking help. So what we know is that there's still a lot of room for improvement, and there's plenty of opportunity to better support plan members in getting connected to the care they need, not only for ADHD, but other concurrent mental health conditions. So when employers are thinking about how to best support their employees in managing ADHD, we'd like to provide some things for consideration. The first is providing education and fostering a workplace culture where it's safe for employees to disclose their ADHD diagnosis. The goal of psychoeducation really should be to empower individuals, providing them with information on how they can impact their daily functioning, what are the treatment options, what are potential avenues for optimizing function. Demystification could be incorporated into workplace wellness strategies. It could be the focus of targeted wellness campaigns as it relates to mental health. As I mentioned, a positive workplace culture is really, really important. And I think that ties into the availability of workplace accommodations. Disclosure of a diagnosis is very personal. It's a very personal decision. And I think an employer would need to be educated about ADHD as a medical disability and understand that duty to accommodate, and hopefully view accommodations as a win-win and an opportunity to increase productivity for both the employer and for the employee. And the final thing I'll touch on is perhaps the possibility of investing in coverage for psychosocial interventions. So as I mentioned, a wholesome approach to treatment, something that includes behavioral approaches, is typically the most recommended. So coverage for things like CBT, cognitive behavioral therapy, or mindfulness training, both have been shown to lessen symptoms of ADHD and be very supportive to individuals with a diagnosis. So on this next slide here, we've provided some online resources that can be very helpful. They're evidence-based resources that can be available to anyone really who is looking to learn more about the condition and how to manage it. The one I'll point out is this resource from the Center for ADHD Awareness Canada. And they've developed this document called Understanding ADHD Strengths and Impairments in the Workplace. And this is a really great starting point for employers and employees. It's got a whole bunch of examples for workplace accommodations and strategies that can be very specific to ADHD impairments, which is great. I also want to take a few moments to highlight some specific tools that are available to support plan members that you can consider adding to group benefits plans. The first is the Mental Health Toolkit, a great starting point for an organization looking to develop an effective mental health strategy. There's also Lumino Health, which can be great in supporting individuals through mental health journeys. It includes features like helping people find mental health care practitioners within their local area. There's also Teledoc Medical Experts, which is confidential virtual services that provides an expert review of someone's condition and review of their treatment to make sure it's the most appropriate and most correct for them. And then finally, our latest innovation, our latest mental health innovation, is the Mental Health Coach. And there's some additional information about this on the next slide. And basically, Mental Health Coach was created in response to the rising mental disorder disability claims that we were getting. And the goal here really was to remove some of the key barriers like cost, access, and stigma that plan members were facing in getting care. Now, with this product, what we're really hoping to do is prompting individuals to get care before their symptoms worsen to the point of needing to take an absence from work. All the coaches here are licensed healthcare professionals. They work with members to create a personalized action plan that's based on their risks that are identified through a health risk assessment. Also, it considers, what is available through their benefits plans and what do they specifically have in terms of preferences or unique needs. So far, we've been seeing some really promising results for members who have been using this service. And some of those results are actually depicted here on our next slide. And the first step that we took is to determine, are we able to engage at-risk members? And what we've seen is, yes, we have been able to engage high-risk members into the program. The health risk assessment looks at 13 different risk areas. ADHD has placed number 4 in terms of the highest ranking areas, and it follows anxiety, depression, and sleep as also very high-risk areas where members are screening. The service is helping individuals improve their symptoms. So 93% of those people who have been reassessed have reported experiencing a 10% or more improvement in their symptoms. And often this has been a result of adding lifestyle interventions or seeking additional treatment as part of a recommendation from the program. Now, in terms of ADHD specifically, going back to our specific spotlighted topic, the mental health coaching program has been helping members create goals to help them be less distracted. So perhaps if they have a large project, it helps them kind of break up this project into smaller tasks that are able to be prioritized and get done. So that's kind of an example of how the mental health coach works. So that kind of brings us to the end of our final section of this presentation. And so I'd like to leave you with a few closing thoughts on mental health and ADHD. And that's that, we know that ADHD can profoundly affect someone's work life. It can definitely contribute to higher absenteeism and lower productivity. We've seen ADHD drug claims and claimants are growing. It's an important condition for employers to consider as part of a broader conversation of mental health and mental health strategies. There certainly remains an opportunity to better support employees in accessing the care they need, as well for ADHD, but also for other comorbid mental health conditions. And finally, there are a lot of tools and resources available out there for employers to consider implementing as part of their mental health strategy, but also their workplace benefits programs. So that's all for us. I think on behalf of Tyler and I, we just are so thankful for all of you sharing this time with us. And I think we'll take any questions, and I'll hand it over to Caroline.
Wonderful. Thank you so much for that presentation. Okay, I'll look at the Q&A chat box and feel free to add more if we've got time. We've got a few minutes here. So lots of trends and potential solutions discussed today. How would you suggest a plan sponsor goes about identifying the right solutions for their plan?
Yeah, so maybe I'll start on that one, Caroline. I think it's a great question, and in some of our organizational health, so when we're looking at like disability and stuff like that, we use a model, a 3-step model, evaluate, plan, and then action, and I think a lot of that can be taken into the pharmacy side as well. And so I think when we talked about some of the trends, again, so there is lots of data available on drug programs, so your top drugs, top disease states, all those sorts of things. But I think we also talked about today, again, a lot of other elements. So workforce information, in terms of like employee sentiment surveys you may have done, demographic information. So we talked about, chronic diseases and aging. And so, pulling the picture together from various sources of data, starting with like kind of the evaluation, what are our biggest health risks today, needs in the organization? And then as we look forward 2, 3, 4 years, what might those be, and are those the same? The second idea would be planning. And so again, using that data then to inform what strategies we might want to implement short-term and long-term in terms of impacting some of those changes. And again, your SunLife account exec group representatives would be great in terms of the options we have available. So again, Denuja talked about today, but other things like some of our managed formularies, like our evidence-based drug plan, would those be a good strategic fit for your program's philosophy and objectives? And then the last one, like Caroline, actioning. And so again, in terms of implementing or affecting some of these trends, we have to take action on some things. And so again, and that gets back to kind of measurement on, did it have the outcome we expected? And if not, okay, what tweaks are we going to make? So again, I think the evaluate, plan, action, there's some like amazing advisors in the room today, I know, that can help with these strategies as well, but encourage everybody to really look at the data, because especially on drugs, there is a trove of data to help with those decisions. So yeah.
Great. Next question is, Denuja, you had talked about ADHD and certainly looking at different work accommodations. Are there certain medically supported accommodations that might be required in the workplace?
Yeah, that's a really, really great question. I would probably reiterate to start that disclosure can be a very sensitive issue. It's really complex and certainly, a personal decision. And while I think disclosure is great because employers can gain a better understanding of, workplace behavior, and I think there's something to recognize is that employees may fear being viewed negatively, or, there's perhaps a chance for increased stigma, misunderstanding, or it's really just a vulnerable opportunity for vulnerability there. So I think, an employer needs to be educated, as I said, about ADHD as being a medical disability and really understand this duty to accommodate. And as far as your question, I would offer maybe a few potential accommodations as examples. So for instance, if an employee was experiencing symptoms of distractibility, Perhaps flex time to facilitate focused work is an option. Perhaps working from home, perhaps supplying noise canceling headphones or white noise machines, or moving from a workplace of sort of high traffic to low traffic. On the other hand, if someone was experiencing symptoms of hyperactivity, perhaps they would be better suited to work in an environment where they're having structured breaks, allowing them to sort of move around, or maybe they should be given a more private workspace. So if they are sort of tapping or fidgeting or experiencing things like that, it's not disruptive to other employees rather. So these are really just examples, and I would say that there are a lot of strategies and possible accommodations. And I think the most key thing here is that there may be required a trial and error process. Everybody's extremely different, and I think they should be afforded that opportunity to try out a couple of different accommodations. And I would also just point to the resource that I had mentioned on one of our previous slides, that document that I called out, and that has a whole list of really excellent accommodation examples.
Awesome. Great. Okay, the next one. Unless a product listing agreement is lowering a drug cost below the pooling threshold, how exactly would it benefit a plan sponsor?
Yeah, so this is a great question. We get this, and I probably am not going to do this justice, Caroline, in 2 minutes. But I figure I'd share a few thoughts on that. First, Denuja did talk about in terms of sometimes right now, when we talk about product listing agreements, it often just gets interlinked with biologics and biosimilars. And so I wanted to start out with that the vast majority of our listing agreements are actually not on biologic medications. So outside. So sometimes the two get linked together, but it's important to separate the two topics. So they are part of our strategy for the management of that, obviously, but way broader implications for that. So a couple of ones I'd call it as examples, and happy to have a dialogue after. One, naturally cost savings, even if it's not under the pooling level, to the extent that we can impact costs that would be beneficial to the development of pooling charges. So in that context, I'd say when we're looking at decisions too, in terms of whether we're going to list a drug or not, and when we're thinking about access, price can be an important consideration there. So to the extent that creative reimbursement agreements can allow us to facilitate access under the plan, I think that's another important one to consider. Like if the original price point wasn't at an acceptable level to list. And then the other one I would comment on, and sometimes we talk about as these agreements are just it's just a cost reduction mechanism at the front end. But other creative, when you think of some outcome-based agreement potentials, or maybe scenarios where, say, it's a therapy where there's a higher potential for failure or non-adherence to the therapy. And so a model where maybe the plan doesn't pay for cost for a period of time until the member is established on the therapy, on the drug. And so we've determined that this is going to be a suitable medication for the member. And so there's lots of permutations on that. And I want to acknowledge the question. I think it's a great question that and I'm owning this as SunLife, could do a better job talking about the value of some of those and the collective benefits on that. But that was a great question. So yeah.
Awesome. In a kind of similar vein, do you have an update on when Ontario might launch its biosimilar program? This was announced more than 2.5 years ago. Other provinces have moved forward since then.
So great question. Nothing official right now. So you would have seen on the slide, it was in gray and a slightly different color than others for exactly that reason. Very much correct that there was an announcement, and then the pandemic had kind of delayed all that. So now that there may be more bandwidth from some of the governments, as we get into next year, that's one we are closely monitoring, but nothing on an official date yet. So.
Okay. Great. Okay, quick question about where can we get the slides? I know I can answer for our Benefits Alliance members. We're going to be posting these in the Knowledge Library along with a recording of the session. And I will check for those that are this was open to the public. So I will find that out and circle back. Outside of that, when it comes to plan member education, I sit here and I listen to the presentation, see the presentation, and from my perspective, a lot of people would struggle, whether you're an advisor, plan sponsor, of how to educate plan members. What are one or two items when it comes to drug plans that you would recommend advisors and plan sponsors focus on education of plan members in this very complex world?
Yeah, I'll maybe call it a couple, and it's a great question because the members are a pillar in kind of that stakeholder group that can play a key role. And so a couple of things would be leveraging some of the tools available. So we did talk about today, we do have information on like lower cost alternative medications, like our digital coach that can assist members in some of these behavior changes. But I think education on other things, when we think about dispensing fees in our provider search or maximizing 100-day supply and all of those things that can be beneficial to the member, but also to the cost of the plan. Those would be a couple of quick ones I'd call out at time, Carolyn. Yeah.
Okay. Wonderful. Well, I think that wraps up. We will send a note to attendees that had registered here for information on accessing slides and presentation. But I want to thank you so much to both Denuja and to Tyler for joining us today. Really appreciate